Is Dr. Ellam, Professor Ellam from Kuopio, Finland, on perioperative infusion therapy.
Hello. I must thank the faculty for inviting us and the experience of Kuopio to share with you here. It's a great honor to speak in this audience. Topic of the day is my topic of the day is perioperative fluid management in the OR setting. Kuopio University Clinic is a rather small one, and we do only adult cardiac cases, so this is about the adult patients. Some disclosures: I have received educational grants from the industry and also lecture fees. Well, today we're gonna go slightly over, there's a time issue, of course, of the term quadruple hit. We're going to go over fluid therapy with crystalloids, with albumin, with red blood cells, and we're going to take a sneak peek of the role of the minimal invasive extracorporeal circulation in the fluid management. A couple of years ago in JAMA, colleagues from the Duke University published a nice editorial to the ALBIX trial. And this is the first time I saw this expression quadruple hit, but it summarizes very nicely what happens to our patients in the cardiac OR. So there is exposure to the non-pulsatile extracorporeal circulation. There is ischemia and reperfusion injury, controlled trauma from the surgery, bleeding and hemodilution. And all of these above will determine the need for optimal fluid therapy. And if we do not do it correctly, we can cause excessive bleeding, fluid overload, acute kidney injury, and serious reaction. So everybody who's been in cardiac OR has seen hypovolemic ventricle, so we need to do something about it. Excellent survey conducted in Australia. They handed out a questionnaire to the different doctors, anesthetists, cardiac surgeons, intensive care doctors, and they asked what's your choice of fluids? First choice, second choice, and also vasopressor use. So as you can see, mainly the first choice of the fluids is balanced crystalloids, and then albumin. Some saline use. Vasopressor use is, trivial, noradrenaline and vasopressin. This mimics quite nicely what we are using today in the cardiac OR. Albumin, most of the cases here is 4% albumin, only some cases 20% albumin. So, turns out it matters what we use. Saline versus balanced solutions in crystalloids. I think it's a groundbreaking research from Semler, published in NAME 6 years ago already. 15,000 patients, and they looked at the compared the use of the saline and the Ringer lactate and plasmolite. Mm-hmm. And interestingly enough, they found that the use of balanced crystalloids resulted in lower rate of death and new renal replacement therapy and persistent renal dysfunction. So from that on, I think the use of saline has decreased very much in the anesthesiology departments and the ORs, and also in intensive care. Nice paper from Switzerland, published in 2019. And they compared Ringer lactate and Ringer acetate. Both are balanced solutions. And they looked at the inner pressure requirements, hemodynamic profile of the patients in the OR and in intensive care. And they found no difference between the solutions. So both of them are okay to use. So albumin. There are many benefits in albumin. It's the main determinant of the plasma oncotic pressure. It has protective effects on the endothelial glycocalyx and also on the microvascular integrity. It reduces platelet consumptions and prevents acute kidney injury. So people are using albumin, and team in Helsinki made an excellent randomized controlled trial, ALBIX trial, published in JAMA 2 years ago, 1,400 patients, and they used 4% albumin versus Ringer acetate. And they looked at the major adverse events. And turned out that the use of albumin did not reduce the risk of major adverse effects. And for that reason, they don't recommend using it because albumin is quite costly, at least in Finland. So why use it if there is no benefit for the key issues as the major adverse effects are? The next year, they published some additional analysis from the same material, and they found that the use of 4% albumin resulted in increased blood loss and also higher class in the chest tube drainage. Also, argument against the use of albumin. So, albumin versus crystalloids, some different papers. Excellent paper from, in my opinion, from Australia. They used 20% albumin versus crystalloids, and the crystalloids were saline and mostly the balanced solutions. Cardiac surgery patients, and they found that the use of 20% albumin resulted in less positive fluid balance, and also they had some hemodynamic benefits as less use of vasopressors. So 20% albumin. Of course, the eternal debate of the colloids, crystalloids will go on, and we will see more research done by this field. Red blood cells. Well, in your setting, we all have the patients who will need the transfusion. But please bear in mind that the transfusions, they come with adverse effects. And these effects are usually dose-related. So if you need to give some blood and you need to undertake the transfusion, so please consider either you go with the restrictive strategy or you go with the liberal strategy. And nice paper from the Carson last year published in NAME. This is not from the cardiac OR, but close enough. They looked at the patients with the myocardial infarctions and anemia. And they found that liberal transfusion strategy did not reduce the risk of recurrent myocardial infarction or death in 30 days. So, and there are more research like this that are saying that restrictive strategy is as good as the liberal. So, minimal invasive extracorporeal circulation and the guidelines. As the previous panel pointed out, Dr. Ashravi, that this is, we have sufficient evidence to support the use of minimal invasive extracorporeal circulation, and a couple of guidelines, one from the United States, the other one from the Europe, and they both state the same, that minimal invasive approach should be considered over the standard conventional system to reduce blood loss and the need for transfusion. Slide from our center research. This is CABG patients elective cases. And the table is in the OR intraoperative setting. As you can see, quite less need for overall fluids in the minimal invasive group. Also less transfusions and less drop of hemoglobin. And as you can see in the graph, 15 minutes after the onset of the perfusion, what's going on with hemoglobin when you are going with the conventional bypass. So this is one of the reasons people are making transfusions. And also, as the last comments were here about diluting fibrinogen and other non-beneficial things. So, to conclude, well, for the optimal perioperative fluid management, we need to take other things also in counter. And we must use, if possible, minimal invasive cardiac surgery techniques just to give less trauma and tissue edema. Minimal invasive perfusion, of course. And the best and the first choice of the fluids are balanced crystalloids. And in light of this research, what we have published today. And if you need to give blood products, red blood cells, please go with the restrictive strategy. Albumin, if you want to use, 20% seems to be better than 4%. Thank you.
Thank you very much. Very nice overview. It's very interesting, and I think this is going to lead to some confusion. But I'm very interested by the study that demonstrated a significant difference in outcomes between normal saline and balanced, ringers, which has always been sort of the anesthesiologist's bias. But problematically, when you look at the literature, these get lumped as crystalloids.
Yes.
When they compare them. And it would be, I think, in light of the fact that there does appear to be a difference between saline and ringers, I think that's going to be one of the confounds we have to look at for in reviewing the literature, because they tend to get lumped together. And I think that evidence would suggest that, no, we need to look at ringers separately from the other crystalloids. Yeah, thank you.
The saline solution intends to create hyperchloremia and acidosis.
Yes, and hypercalcemia, a variety of things.
Sorry, we must move on. We are 2 lectures, 8 the night. And